Hello, everyone, and welcome to the Dr. R Show. We'll be coming to your living rooms weekly to discuss various health topics with the help of medical experts in their respective fields. Meet my two very special assistants, Megan and Christina.
And I am so excited because today is leg day.
And then inhale as you lower back down.
They will be with me every week to give us tips on healthy eating and proper exercise.
Stretch and keep yourself hydrated.
So welcome to my show as we both learn together. Hello, and welcome to the Dr. R Show. Today we're delighted to have with us again Dr. Bevan Thomas, Director of the USMD Cancer Center. Previously, we discussed prostate health and how prostate cancer is diagnosed. Today we'll be continuing our discussion with the many varied and innovative treatment options which are available, and a few of these techniques may surprise you. There's so many choices available in treating prostate cancer, it can make your head spin. You can freeze it, you can heat it, you can zap with radiation either on the inside with seeds or on the outside with x-ray machines. You can cut it out, or you can do nothing. What is the patient to do in trying to figure out what is the best option for him? Dr. BT, why is the treatment of prostate cancer so complicated? Why are there so many options?
So it's a great question, Jay. And one of the challenges that we have with prostate cancer is really looking at how we approach prostate cancer as a whole. One of the first things that I tell patients with prostate cancer is that you don't all have the same disease. So the first thing when a man is diagnosed with prostate cancer is we actually grade that cancer. And so we'll grade it actually according to what's called the Gleason scale. And that Gleason scale, or the Gleason score rather, actually grades it so it's how aggressive that cancer is. And that's really the starting point with what we have with patients with prostate cancer, is 99% of those patients have what's called adenocarcinoma. And adenocarcinoma is actually arises from that prostate itself, and then it starts to grow. And this is what we almost invariably call prostate cancer. They're very rare, called small cell carcinoma, which we rarely see. But that's how we start this discussion, because prostate cancer is such a varied of diseases that you can have the low-grade disease, you can have intermediate-grade disease, and you can have high-grade disease. So depending on the grade of disease that they have, really depends on where we go from there. Do we follow it, or do we consider following it, or do we do something more aggressive?
Now, you mentioned Gleason grades. How many Gleason grades are there?
Yeah, it's a great question. So we start off, in the old days, we actually would grade those cancer cells actually from a scale of 1 through 5. So 1 is the lowest grade that you can get. And I tell people, basically, it's like an egg. So if I have a regular egg in my hand and I have small little cracks in it, well, that's sort of the earliest, that's the lowest grade. Now, to make it a little bit more complex, we used to have 1, 2, 3, 4s, and 5s. 1 mean the least aggressive and 5 mean the most aggressive. But now what's happened is the 1s and 2s have actually been merged over with the 3s. So really, we have 3s, 4s, and 5s. Right? So 3 is the lowest grade. So if we compare it to an egg, we have an egg with some cracks in it, and that's what's called a Gleason grade of 3. So we sort of, that's an introduction or the earliest grade that we have on prostate cancer. Then we start going up that scale, 3s and then 4s. I tell people that you get the crack in the egg and you start getting some yolk that's spilling out of it. That's a 4. And then 5 is when you smash the egg and you really kind of don't have Humpty Dumpty is pretty much smashed on those things. Okay, so that's part 1, is we're looking at what those cells look like. But we have a score, and that score, you're actually going to add 2 of those numbers together, right? So you could have a 3, again, some of those cracks in that egg, but you could also have a 4, again, some of that yolk spilling out. So you have an additive score of that is actually 7. So you have a 3 plus 4. So you always have 2 numbers for those patients. And again, so we do the math here, is that we've either got a lowest we can have is 3 plus 3 equals 6. The highest you can have is a 5 plus 5 equals 10.
Now, there's also stages in addition to grades. So what are the stages?
So stages are totally different, because stages are really looking at how far that cancer has actually grown. So let's go back again. So we have a grade. If we have a patient with a lower grade prostate cancer, which again is a Gleason 6, the chances that that patient's going to have a more advanced stage, which is outside the prostate, into the lymph nodes, into the bones, is actually extremely low. Now on the flip side of it, if we find a man who actually has that higher grade cancer, or that higher score, that Gleason 10, that patient unfortunately has a higher risk, because that cancer will grow faster. It can get outside the prostate to the lymph nodes and to the bones.
So if you have prostate cancer in the lymph nodes, does that preclude a radical prostatectomy? So
another great question. So we've had this discussion before. And in the old days with prostate cancer, even actually before I was training, or actually when I was training in the 1990s and early 2000s, is we would do surgery on a man. And then the lymph nodes, we would actually take the lymph nodes out, and if there was actually cancer in the lymph nodes, there was a fair amount of time that we would actually stop doing surgery because we couldn't cure those men. Well, those days have changed, and one of the reasons why they've changed is because the cancer, if the cancer actually gets the lymph nodes, we can still actually have a fighting chance of curing those patients. It's tough, though, because the more cancer that's actually in the lymph nodes, in other words, the more lymph nodes that are involved, it becomes much more challenging for us to actually treat those patients and cure them. We can keep them around for a period of time. So now what's happened is that there's been a paradigm shift. We're seeing more and more men with these cancers that are still localized within the prostate because we're getting better at finding them early. And so we're finding fewer men actually that have cancer in the lymph nodes. And as a result, we're basically being as aggressive as possible in treating those patients with not just surgery, but all the potentially, radiation, hormones, and then sometimes potential chemotherapy.
So now, if the prostate cancer is still just in the prostate, hasn't gotten through the capsule, but you still have cancer cells in the lymph nodes.
Right.
Is that still a candidate for total removal of the prostate?
So it is, but it's, it becomes a little bit of a challenging question. So I think the first question to ask ourselves, or first really for understanding, is what is a lymph node, and how do lymphatics actually behave? And I tell people the lymphatic system is basically sort of like the garbage system. Any solid organ that you have in your body has the lymphatic system, right? So I tell people, it's sort of like, you put your garbage out, twice a week, right? Or, so you take all your stuff out to the curb. Now the problem with the lymphatic system is that it basically just clears all that stuff out. When there's cancer cells in there, it's like putting your couch out, and all the garbage men are in charge of doing is actually taking out the regular garbage. And so what happens is that Tuesday afternoon when you come back and your couch is still there, what happens is, like the cancer cells, is that they can't clear that thing, they can't clear that big area out. And that's what happens with the cancer cells. The cancer cells actually get stuck in that lymphatic system, in those lymph nodes. So again, the lymphatics is like a fluid system that just drains that solid organ. So when we see those cancer cells get outside the prostate and into the lymph nodes, almost invariably we see the lymph nodes actually start to enlarge. And then what happens is, because those cancer cells have to get through that filtration system, and then they get stuck. And then when they get stuck, you can actually see those on an X-ray, and then they start actually filtering through there, and then from the lymph nodes they actually get to the bones. So once we understand what the lymphatics do, is again, they work as a filtration system, then we figure out, okay, what can we do with these patients? Again, so go back to where we were talked about originally, is that of those patients with the lymphatics that have positive lymph nodes, do we treat those patients? Well, we're becoming more and more aggressive, because we know that if we find those patients with those lymph nodes and we take those lymph nodes out and we aggressively take the surgery and we take the prostate out, we do have a fighting chance. We can actually consider doing hormones and radiation in those patients, and they actually do have a better chance of us actually keeping them around for a period of time. It becomes much more challenging for patients with actually cancer that actually is beyond the lymph nodes, or they have multiple areas of lymph nodes where it becomes, you're seeing these big bulky lymph nodes, about the size of golf balls, let's say, and then also an area that maybe even potentially in the bones themselves. We can't cure those patients. And so is it advantageous for us to do surgery on those patients? Those are the subset of patients that we start looking at a systemic approach rather than just at what's called a localized approach, which is surgery.
And now for a short break. When we come back, we'll talk further with Dr. Bevan Thomas about how prostate cancer is currently treated. Please stay tuned.
Hey guys, I'm Megan and this is Christina, and today's tip on Inside Fitness is all about the workout buddy and the medicine ball. Now, medicine balls can add some variety, and working out with a buddy can actually make it a little bit more fun.
And medicine balls you can pick up at any sporting goods store and work out from the comfort of your own home.
So we're going to do a few partner exercises with the medicine ball today. So the first one we're going to do together is just a twist to the side, where we pass it from side to side, going in a complete circle. Now really engage your abs and engage your obliques. Try not to twist your hips too much. You really want the action coming from your abdominals. And then don't forget to go the opposite direction to stay even on both sides. Sorry. Now the next one we're going to do is through the leg pass. So you bend forward, pass the ball through the legs, reach up towards the sky, get a nice good stretch, and then bend back forward and pass the ball back through the legs. Now this one's going to increase your heart rate, but it's also going to give you a nice good stretch all the way through your body.
You can really feel it in your whole abs too.
So again, do about 3 sets of 10 to 15 repetitions of this exercise. So our last exercise today is the burpee toss. So this will actually give you a little bit of an aerobic workout as well as a strength workout. So you face each other and you pretty much just do a burpee on top of the medicine ball. So you come down, jump out into the plank position, jump back in, and as you're standing up, you toss the ball to your partner. And then she does a burpee and passes it back. Now you're really going to feel this throughout your entire body, and you should do about 3 sets of 10 to 15 repetitions of these. So these were just a few exercises that you can do with a partner and with a medicine ball, but there are plenty of them out there for you to try.
So we'll see you back here next week on Inside Fitness. We hope you learned a lot today with the medicine ball. Make sure that you never skip your cool down or your stretch, and we'll see you next week. Hi, welcome back. I'm Christina and this is Megan, and today we're talking about high protein. Now, protein is something that you hear a lot about when you're dieting, but are you eating the right types? So protein is a macronutrient necessary for your body's growth. It gives you a lot of energy, keeps you satisfied longer, and it's a lean way to snack. So today we're going to give you 10 options of the foods highest in protein.
So first on the list we have fish, which is not only high in protein, but it also has a lot of the omega-3 fatty acids, which can lower your blood pressure and your triglyceride level. Then we have lean chicken breast, which I personally like to make stir-fried chicken where you just throw in some vegetables, a little bit of olive oil and lemon pepper seasoning, and then you're all set. Lean beef and pork chops are also great sources of protein.
So in talking about stir fry, as Megan mentioned before, of course you can do that with, fish, poultry, meat, but if you're a vegetarian, you still want to kind of have that taste. Tofu is an excellent option. Tofu is actually made by coagulating soy milk and pressing the remaining curds into blocks, as you see here. Now I know it doesn't look terribly appetizing like this, but you can actually season it just like you would season chicken. Additionally, soybeans, see there's that word again, those are a great way to get a lot of protein into a nice, even salty snack if you wanted to flavor it that way. 1 cup of soybeans is approximately 29 grams of protein. Now that's a lot.
Now another non-meat source of protein is some cottage cheese or some non-fat mozzarella cheese that we have here, and those actually provide the highest amount of protein per calorie. And notice I said non-fat because if you get the full fat cheeses, they can give you 1 gram of protein per 20 calories.
So then kind of keeping in line with those dairy products, the next thing on our list we have milk, yogurt, and soy milk, or even almond milk, which you see here today. The yogurt that I decided to show you guys is actually Greek yogurt. Now I know this has been kind of a trend recently, but what actually makes Greek yogurt Greek is the removal of the whey. And what this does is it makes it 40% less sugar, 38% less sodium, and almost double the amount of protein that you would get in a regular yogurt. So all in all, when you're looking to sustain your hunger and sort of satisfy your cravings, that's definitely a better way to go. So next on the list we have eggs, or particularly egg whites. Now the wonderful thing about egg whites, it's not bad to eat the whole egg, right? You're still getting a lot of protein, you're getting a lot of nutrients, but egg whites in particular, they're 1 gram of protein per 4.4 calories. So in 1 egg white, you get 4 grams of protein when less than 20 calories. So it's a really, really great option. So then we have nuts and seeds. Now, of course, nuts and seeds are full of protein, but they're also an excellent source of fiber and unsaturated fats, in addition to omega-3 fatty acids. So hopefully this gives you some ideas next time you're at the grocery store about how to include a little bit more protein in your diet. We'll see you right back here next time.
Welcome back to the Dr. R Show. Dr. Bevan Thomas is back with us talking about the treatment of prostate cancer. Welcome back, Dr. Bevan Thomas. Now let's talk about the actual treatment. Once you've decided watchful waiting is not an option, what are the available treatment options? How do you decide what to do?
So that's a great question. That continues to remain one of the more challenging things for patients today with prostate cancer is when a man gets diagnosed with prostate cancer, again, the first question we ask ourselves is this a cancer that we need to treat, or is this a cancer that we can follow? And when we follow prostate cancer, we don't just forget about them when we say, don't worry about them. That's what we call active surveillance. So when we go back to our original point, we talked about the grade of those cancers and the stage of those cancers. So early stage cancer, in other words, it hasn't gone beyond the prostate. grade of those cancers, lower grade prostate cancer. So if it's a lower grade prostate cancer, it's going to grow slower. And if it grows slower, that's a patient that we can potentially follow. So we start with really the basics of this. If we've got a low grade prostate cancer, we can follow them, and that's what we call active surveillance. And it's called active surveillance because we're actively following those patients. And the way that we actively follow them is we follow that PSA to make sure the PSA doesn't rise up significantly. That's part of the issue. The problem with the PSA is it's not as helpful as we'd like to look at for patients with prostate cancer. It's helpful really for the diagnostic part of it, but really looking at that PSA rise up, there's a lot of things that it really can go wrong. That PSA can bump up, it can come back down again. So it's one minor component of this. The big part of actually following those cancers is actually a repeat biopsy, which patients hate, and we get that, but we've got to take a look at that prostate, and we've got to make sure, and so we'll target specific areas of that. What we do at USMD now is we actually will use MRIs, where we'll look at areas that we can target in the prostate itself, and then we want to make sure that those patients continue to remain good candidates because they've got a lower grade cancer. Because if you've got a higher grade cancer, then think about it, if that cancer gets outside the prostate, it becomes much more challenging for us to treat those patients. So that's called active surveillance. The second thing we do is we say, okay, maybe this patient isn't a good candidate actually to follow this cancer, so we treat, right? And exactly what we talked about before is that if you treat it, and I tell patients, let's keep it to the basics, we can either remove it or we can destroy it. And it really just depends on which way we go from there.
And so, what are the surgical treatment options?
So surgical treatment options is that if we remove it, in the old days, prior to 2002, we used to do these things open, which is a big incision, and just like it's in the same way as the spine surgery, we've really come a long way in terms of the field of surgery. I mean, certainly for urology-wise, a majority, almost all of the cancer surgeries that we do these days, actually we're doing laparoscopically, little keyhole incisions. So we use a robot for this. It's called a robotic prostatectomy. Little keyhole incisions, we take the entire prostate out. You can't take part of the prostate out, because if you only take part of the prostate out, two things can happen. Number one is that it can bleed and then you can have problems. And number two is that you can also leave other cancer behind. So we take the entire prostate out. And the way we do that, again, laparoscopic, robotic, little keyhole incisions. We take the entire prostate out, put the urine channel back to the bladder, and we'll show you a video on this, and we put everything back together. It's about, give or take, just under 2 hours, and patients go home the next day, and they actually do very well. What we do at USMD is we actually do what's called a catheter-less prostatectomy, which is where we don't leave a catheter in the penis when they go home, which is a huge bonus because there's no good selling point on that at all. And that catheter, now what we do is we leave a little catheter in the lower belly. And that catheter stays in the belly, so we actually drain that bladder and let that area rest. So that's surgery. And actually, a lot of patients can actually do very, very well from that. So that's if we take it out. And we're doing, less than 10% of all the surgeries in the United States now are actually done with open. So we do everything robotically, almost invariably. And then we can destroy it, right? So how do we destroy that? So we can either destroy it with heat. That's called high-intensity focused ultrasound. It's not available in the United States right now. And one of the problems is that it hasn't been FDA approved. So that's an option. Again, you've got to go down, offshore, either Mexico, et cetera, to kind of get that done. The other thing is radiation. Radiation is actually done here in the United States. You can radiate outside the prostate, or you can put radiation directly into the prostate. If you put radiation in the prostate, those are radioactive seeds. If you do it on the outside of the prostate, you're actually trying to basically destroy the DNA. And then, of course, the final thing is actually cryoablation, where we put these little needles in the prostate. You put those needles in there, and ice actually turns around it. And then what we're doing is we're focusing. We're forming really like ice castles inside that prostate, and it just turns into scar tissue.
So now you mentioned freezing it, heating it, and radiating it. And when do you use which modality?
So, and that is a $64,000 question, is that how do we choose what's best for the patient? Well, the first thing we do is you want to sit down with your doctor and you talk about where are you? Where is your cancer? Do you have a high-grade disease? And the high-grade disease are going to require a much more aggressive approach on this. If you've got a low-grade disease that we talked about, is this a cancer that we can follow? And then, unfortunately, or fortunately, there's a lot of cancers that actually lie in between. And so it's really finding out which treatment modality is best for that patient. As patients get older, above the age of 70 or 75, and if they have an intermediate or higher grade disease, we actually start looking at potentially at less invasive approaches, even lesser invasive actually than doing a robotic surgery on those things. So sometimes those patients are actually better suited for radiation. As patients are younger, we worry about the potential of long-term issues for the radiation that could affect, not only just the surrounding tissue, but also some of the area itself, and could there be a recurrence of that cancer in the prostate? So those patients actually tend to lean over a little bit more towards from a surgical approach. So there's not really a cookbook approach which says 60-year-old man walks in, he's got Gleason 7 prostate cancer, everybody gets surgery. So it's a very, very complex situation. I think I try to get my patients as educated as possible on that, and it's really understanding the risks and the side effects of all of those things and what might be better for that particular surgery, or rather, what particular cancer that patient has.
Say you freeze it and it comes back. Can you then heat it or radiate it?
You can. So, with radiation, you can't really, for the most part, give any more radiation because everything just turns into mush. If you freeze it and the cancer comes back, if it's still localized within the prostate, you can actually go back and refreeze it again. So it's because it's a local approachment on that, or treatment. If you do surgery, you can't really go back and do more surgery as a whole because you've taken the entire prostate out, so you can't go back in and just try to take more of that area out, even if there's a recurrence there. So you're really looking at, if you try to destroy that tissue, can you go back in afterwards? One of the bigger challenges that we have is that if we ablate this, and if we treat it with whether it's radiation or cryo, specifically radiation, there's scarring in that area. So it's far more challenging for us to go in and do surgery after there's been radiation than vice versa. Doing surgery actually before radiation, then radiation after surgery, those side effects are significantly less.
Great information, Doctor, and thank you for being on the show. And thank you for watching this edition of the Dr. R Show. Until next time, healthy living and goodbye. Good job, BT.
Good. Great.
All
Thanks.
right, high five.
I appreciate it, Ted. I hope the show works.